Good morning, everybody, and welcome to CMH Family Medicine for our last Friday of the month HIV case discussion meeting or district HIV meeting. I would like to start off by saying thank you to Dr. Fuentes and Dr. Siyakane, who created the slides for this presentation. And Dr. Siyakane actually presented this morning, but unfortunately it looks like on Zoom there was some technical problem on the other side, and the recording it came out with literally a quarter screen. So this is a re-recording of the pre-exposure prophylaxis presentation that was done by Dr. Siyakane today on the 24th of March. And in this presentation today, we're going to be focusing on pre-exposure prophylaxis as one of our HIV prevention methods that's become very much more in use in the last couple of years. So let's just start off a little bit and talk about HIV incidence. So whenever you talk about prevention, we always want to know how many new people are actually getting infected. And at the moment, since the beginning of the HIV epidemic, 84.2 million people worldwide have been infected with HIV. And although we have lots of prevention options now, we still find that 4,000 people every single day becomes infected. And you'll notice a quarter of those, 1,100, is the youth between the ages of 15 and 24. And if we continue on this trajectory, by 2025, there'll be another 1.2 million people with HIV. And there's actually a target of 370,000, which the moment we are not yet reaching. But there is good news. So since 2010, we have actually seen a huge fall in global annual HIV infections, as well as in South Africa, and this is largely due to the rollout of the ARV program. Also important is, and we'll talk a bit about that today, is what we call key populations, which makes up less than 5% of the global population, but actually is contributing an incredibly large amount of those new HIV infections, and these stats are from 2021. So that is a concern, and what we need to look at is how we provide access of care to our key populations. But we're also seeing that we are getting more and more people on ART, although that's slowing down. So for example, in 2021, there was 1.47 million people started on ART, and that's actually less than we've seen in previous years. And then just a small add-on is just to note that we are still concerned particularly about the infection of children. 4% of people living with HIV in 2021 were children, but they still bring a very high burden to age-related deaths. And I've got a couple of maths just to put South Africa within the global context, and you'll see that the adults and children that was estimated to be living with HIV in 2021 was 38 million. And you can see so Eastern and Southern Africa contributes 20.6 million people to that total amount. And if you look at newly infected people, just in the year 2021, there were 670,000 people newly infected, which was almost half of our total global number of 1.5 million. And then also in deaths, almost a third of the deaths worldwide, 280,000, was happening in Eastern and Southern Africa in 2021 from AIDS, in an era when really nobody should be dying from AIDS. Some South African stats, so almost 14% of our population is HIV positive. That's a very high population, almost 1 in 8 people. And we have seen an explosion. I mean, this has literally all happened in the last 20 years. By 2002, we already had 3.68 million people HIV infected, or that was estimated. And in 2022, we are currently sitting on 8.45 million people in South Africa that has HIV. And the worry is the spread of that. So a quarter of our women, South African women in their reproductive ages, is HIV positive, and that also brings implications for pregnancy and birth. There's good news though. We also do well. We are the largest ARV program worldwide, and we are pursuing our ART program very actively. And life expectancy has increased dramatically since the rollout of ART in 2005. So although we have a lot of people living with HIV in South Africa, the death rate has come down considerably and life expectancy has increased. So there's some targets that's been set by UNAIDS. Everybody knows about the 90-90-90. Well, these have been upgraded, and they've actually made these more granular and more interesting than just those 3 particular targets. And they divide those in what they call social enablers, integration of services, and then specifically looking at HIV services. So when they talk about social enablers, and we all know this, that it doesn't help that you've got a lovely HIV program, but you're unable to globally implement it. And so they're looking at the global arena of HIV prevention and care. And there's three sort of levels that they're looking at. The one is to look at the legal environment and access to justice. So the goal is that less than 10% of countries must have punitive policies that reduce access. And just this last week, Uganda has just passed a law making it illegal to even identify as somebody with LGBTQI plus identifying. So that means even if you just saying you're gay has become a criminal offense, as well as anybody that enables or affirms people who are LGBTQIA plus. So you as a healthcare worker, if you're giving advice to somebody about anal sex, for example, or you're giving advice around pre-exposure prophylaxis for men who have sex with men, it would actually be illegal in Uganda at the moment. It's just waiting for final ratification from their parliament. So that is a worry, because we actually want to try and improve the amount of countries with access. We also want to reduce the number of people who are experiencing gender-based violence, particularly women, but all people, and get that to less than 10%. And we want to reduce the amount of stigma and discrimination experienced by people living with HIV, and the goal there is also less than 10%. The other target that they've set is around integration, and that is to do with how our different services talk to each other. So anybody with HIV should easily be linked to any of the other services. So if they need care for their communicable diseases or gender-based violence or mental health, it all really should happen in the same place. And similarly, if you're in a center where you're looking after somebody with communicable diseases, you should also be able to manage their HIV. So the HIV services has got 3 target levels. The one is now no longer the 90-90-90, it's now the 95-95-95. And that's still very familiar. So 95% of people with HIV should know their status. 95% of people who are HIV positive should be on antiretroviral therapy. And 95% of those on antiretroviral therapy must have suppressed viral loads. And in South Africa, how are we doing? So according to the Global AIDS Monitoring, we're actually doing very well with people knowing their status. That's obviously projected on how many people we think in South Africa is HIV positive, and we believe that 94% of them know their status, but only 74% of those of people living with HIV is actually receiving ART, and only 67% are virologically suppressed. So that is something that we'll still need to be working on. The second target is particularly to do with women and children. So 95% of women with reproductive age have access to reproductive services. So that includes contraception, antenatal services, and any services around birthing or having babies. 95% of pregnant and breastfeeding women need to be virally suppressed. So we've actually specifically taken that out of our target 1 and focusing on that. And then very important that HIV-exposed children, 95% of them must be tested. So unfortunately, the children who are getting infected are actually usually also the women who are falling through the PMTCT cracks. And we need to be able to identify those children and make sure we identify children who have been exposed and possibly infected. And then the third target is 95% of people at risk of HIV infection are using effective combination prevention options. So that's what we're talking about today. And this doesn't necessarily mean one particular option, but that they have access to a full range and that it can be target made to that specific person. And it's for this particular target that we are doing this talk today. So when we look at HIV prevention programs, the most important, the key one, the one that's up and above, and it's not condoms, is of course the Universal Test and Treat program. If we can test people early, put them onto ARVs, that by far has had and is having the biggest impact on HIV infection in South Africa. And very closely second to that is our prevention of mother-to-child transmissions. So again, putting those with HIV on treatment is probably the best way to reduce transmission. And then we have methods that are not as effective but still very worthwhile using, and we want to make sure condoms are available. Voluntary medical male circumcision definitely also makes a difference. We'll talk today about pre-exposure prophylaxis, which is linked also to post-exposure prophylaxis. Our STI programs, making sure we treat and manage STIs. Still all our risk reduction counseling. This is a little bit to do around abstinence and partners. And with our drug users, the use of clean needles and syringes. So let's delve a little bit into pre-exposure prophylaxis. And importantly, we're going to be looking at the 2021 updated guidelines. So please go and check out your Knowledge Hub. It's a lovely guideline. There's been some changes on that. And that's a Department of Health guideline that we can roll out in our clinics. So in terms of some of the evidence, we actually have some very nice local evidence also in terms of what's happening with the rollout of pre-exposure. And these are two articles that has, particularly from the Eastern Cape, that is looking at how aware our adolescents and young adults are around PrEP being available in the public sector, and also their willingness to actually take this, looking specifically again at young people. And the conclusion, unfortunately, is that there are still very poor awareness, and use of PrEP is still very low among adolescents and young adults who may need it to prevent HIV infection. And I think we need to reflect a little bit as healthcare professionals, how good are we at offering pre-exposure prophylaxis and making people aware of this service in our facilities. So what is PrEP, when I keep on using this word? And the WHO calls it the use of antiretroviral drugs by HIV-negative individuals who are at substantial risk of acquiring HIV. Just note the highlight there. Before potential exposure to HIV to prevent HIV acquisition. So we're basically giving ARVs to an HIV-negative person to prevent them from getting HIV. In our context, we're actually the first country in sub-Saharan Africa to fully approve pre-exposure prophylaxis. And the implementation already started in 2016 when we had some pilot sites and we're focusing on some very specific key populations, but it's now available in all provinces. We have a guideline, and there's been a huge focus on increasing PrEP access. The NGOs have also been very helpful with this. And I think the COVID-19 did not help, because we literally rolled out countrywide just before COVID broke. And so I think the rollout has not gone as extensive as we would have liked. So who's at risk? And firstly, we look at it from a population point of view. So when we look at rollout in South Africa, there's certain populations we want to focus on and you want to be aware of when you're thinking and talking about PrEP. And firstly, the top population in our setting is adolescent girls, boys, young women and men, and particularly the girls, but we are also including the boys here. But the girls have got a very high risk of HIV acquisition between the ages of 16 and 24. And they, therefore, are probably our prime group that we are trying to address. Men who have sex with men was some of our first guidelines, came out around this group, and our gay men has been amazing also in terms of advocating for PrEP access, and has been very much on the forefront of getting PrEP rolled out, as well as our transgender individuals. Individuals who have more than one sexual partner, people who inject drugs, or people with recent history of STIs. And very important also, individuals who recognize their own risk. So if somebody comes in and they say, I'm worried, I would like to be on PrEP, we can give it to those patients. If you've got a serodiscordant couple where the HIV positive partner is not virally suppressed, so just notice that usually when HIV partners are suppressed, that's still your best way of preventing HIV, and it's not necessary for the HIV negative partner to also be on PrEP if their partner is suppressed. Sex workers, certainly one of our key populations. Migrant workers, mainly because of lack of access to services. We need to make sure that they're accessing contraception and PrEP. And then very important that pregnant and breastfeeding women has been given a specific focus now in the guideline in terms of prevention. So they're a higher risk population over the average population. They are women in their reproductive ages, as we know, that have a high rate of HIV acquisition. There's a high incidence in this population. They're sexually active and they don't wear condoms. We know that because they're pregnant. So here's just some of the stats that's informed this guideline. So there's a very high HIV prevalence in some of our key populations, like men who have sex with men, and a recent study also saying very high prevalence in transgender women, and that's mostly to do with them not accessing services. So the problem is that they do not feel that services are friendly, and so they simply don't access things like PrEP or condoms, so we can certainly do better there. Also very high prevalence amongst people who inject drugs, and for similar reasons that they don't always have access to, for example, clean needles. Very high prevalence among sex workers. And again, the issue is not the fact that they're having sex, but the fact that they're not accessing condoms or not able to negotiate a condom use. And then this is an alarming stat that this is from 2021, that 63% of all new HIV infections in sub-Saharan Africa was adolescent girls and youth, so the 16 to 24-year-old group in 2021. And so we're still seeing that the majority of people who are getting infected with HIV are the young girls. This has largely got to do with them being in relationships with men, usually 5 or 10 years older than themselves, who have a little bit more financial power to bring to the relationship. But that also means the girls are less able to negotiate power dynamics and therefore negotiate condom use. And this is one of the reasons that contributes to this very high rate. And we need to give them extra ways of protecting themselves. Now, important when you are offering PrEP, and we talked about integration earlier as well, it's not about presenting it in isolation, but it's part of your package of sexual health services. So anywhere where you're talking about HIV, condoms, pregnancy, STIs, PrEP should also be discussed. And whenever you talk about PrEP, you should also be discussing this whole package of services. And you can see that includes also obviously talking about your partner, screening for TB, screening for mental health. So we need to look at our sexual health services and our contraceptive services being this full package of care that includes pre-exposure prophylaxis. And very important that any person can ask for PrEP. So it's not up to us to decide who qualifies. Any patient is allowed to request PrEP, and sometimes they might be too shy to tell why exactly they feel they are at risk, but if they call themselves at risk, then we can give them PrEP. So also we now looked at it sort of from a population point of view, but of course those are not criteria, they're simply a guide of populations you're going to specifically target. But when you're having your conversation, your sexual health conversation, these are the kinds of individuals that you might want to bring up PrEP in your conversation. So anybody who's been having sex without using condoms, who's had more than one partner, or has an HIV positive partner, who has a partner who they don't know the status of, who has sex while they're under the influence of alcohol and drugs, or young women or men who are these very large age differences in relationships, or an individual who's recently been diagnosed with an STI or often have STIs. So any of these scenarios, you actually want to bring up that conversation of pre-exposure prophylaxis. So all of those people can ask for PrEP, and you now have to decide not if they qualify, anybody qualifies, if they feel they're at risk or if they've got any of those risk factors, but who's eligible. So what is our exclusion criteria, so to speak? And very, very important, probably the only most important real exclusion is they must be HIV negative. You do not want to be giving PrEP to HIV positive patients. And therefore, we're a little bit nervous about patients who are busy converting. So if somebody has symptoms of acute HIV infection like fatigue or fever or sore throat, or body aches, rash or a headache, they might be having flu, but if you're not sure, you're going to actually hold off until they have a negative HIV test 6 weeks later. The patient obviously must be willing and able to take PrEP. There must be no contraindications to tenofovir or FTC for any reasons. And we want adolescents and adults to be weighing more than 35 kilograms, and they need to be more than 15 years ideally, but if they're less than 15 years, we want them to have a Tanner stage 3, so they must have some sexual maturity. The reason for this is a very, very, very uncommon side effect of tenofovir is causing a hypophosphatemia. We don't see it very often, but remember we are treating HIV negative extremely well patients. And hypophosphatemia while you're in a growth spurt or while you're still in that early growth stages can potentially affect your bone growth. So that's where that little rule is from. But if they've got already Tanner stage 3, so they're already through their growth spurt, then you can use that PrEP very safely. So our contraindications to summary is obviously if they've got HIV infection or signs of acute HIV infection, and probably the only major contraindication from a drug point of view is usually to do with the kidneys. So, and note there's different targets depending on the age. So if they're more than 16 years old and they've got an EGFR of less than 50, we won't be using PrEP. Or if they've got an adolescent and they've got an EGFR of less than 80, we won't be using PrEP. And we'll talk a little bit more about this when we talk about monitoring. Just remember with pregnant women, similarly as our guidelines, we can't use EGFR, so we'll use the serum creatinine, and if it's over 85 in our pregnant women, we unfortunately cannot use PrEP in them. So what's interesting is with the creatinine monitoring is slightly different than for the guidelines because these are well patients and we are not particularly stressed that they are going to be having kidney problems. So we're trying to make the program as simple as possible. And you'll notice there that people who are under 30 years old and have no comorbidities don't require either creatinine baseline or any follow-up monitoring of creatinine. So we're not concerned about them, and unless something changes, you don't have to monitor creatinine at all. Similarly, right up to 49 years, you can do a baseline creatinine, but the baseline is fine and the patient is fine. You don't need to do any follow-up creatinines unless there's symptoms. It's only once there's comorbidities. So, for example, anybody with diabetes or hypertension, regardless of their age, is going to need a baseline as well as annual creatinine. And once they're over 50, we would want to do some baseline creatinines on them as well. And then the only people who we do follow quite closely is the pregnant patients. So for them, they will still get the classic baseline 3 months and 6 months creatinine. So, nitty-gritty, what do we use? There's actually options, but the only one we have at the moment, we'll talk about the other fun things out there in a minute, but at the moment the gold standard for PrEP is still tenofovir emitricitabine, or we know it as Truvada. They're both NRTIs and make a very nice combination, and the stats are amazing. So you can lower your risk of getting HIV by more than 86% if you're taking it properly, and some studies even higher numbers than that. And for people who are using injectable drug use, there's a 74% risk. And just to show you, this is a lovely smattering of vast amounts of trials that's been done on pre-exposure prophylaxis. And it's just to show that we've also looked at tenofovir gel, and we've also looked at tenofovir on its own, and neither of those particularly performed very well. But all the Truvada studies had some very good outcomes. So how do you prescribe it? So when the patient's done, you've checked all the possible exclusion criteria, and when you initiate your patient after you've done that HIV test, you're going to provide them with a 1-month PrEP drug supply. You'll see them 1 month later. You'll do another HIV test just to make sure we haven't missed somebody that might have recently converted. And after that, you can now write them a 3-month script. And very important, we want to see these patients every 3 months for an HIV test. And when we give them the 3-month script, we also want to give them 3-month PrEP drug supply. So we don't want healthy patients to come to our clinics every month to pick up their PrEP. So they're literally going to go home with 3 little bottles of Truvada. So then they're going to ask when they start their PrEP, okay, now, well, when is this going to start working, sister or doctor? And this is also they've made much simpler. It used to be slightly more complicated for whether it's anal or vaginal sex, but the recommendation now is you can take your PrEP for at least 7 days. Make sure you've been on it for a week before you start engaging in any high-risk sexual activities. And again, say you were in a relationship with somebody and the relationship has ended and you're not going to be having any sex anymore, then you need to continue that PrEP for at least 7 days after the last sexual intercourse before stopping your PrEP. So this is very easy to remember. 7 days before, 7 days after. Some of you might remember they used to use 28 days, similar to the post-exposure prophylaxis. But remember, this patient's already been on PrEP and has already got ARVs on board. And it's now been shown that the 7 days is more than adequate. Nice and simple. Just some little bits of advice on terms of, we all struggle to forget tablets, to take tablets. Please remember, we're not so stressed about HIV negative patients on PrEP. They're not going to get resistance. It's not possible to get resistance to a drug if you are HIV negative, and we're not going to breed HIV resistance if people don't take their tablets. The only thing that will happen if they don't take it regularly is that they might get HIV. So if they miss their dose in the morning, not a train smash, just take it. They must just take it as soon as they remember it. However, if it's almost time for the next dose, skip the missed dose and continue your regular dosing schedule. And to tell them not to take a double dose to make up for a missed one. So some very basic, easy advice. Side effects, well, it's extremely well tolerated, so most people are not going to have any side effects, but uncommonly there might be some gastrointestinal, bit of an upset stomach, some vomiting, maybe even some loss of appetite, very uncommon, might have some headaches, and usually this all clears within the first month. So it's very uncommon to have people discontinuing PrEP because of side effects. Complications in our adults. If at baseline or during follow-up you're having EGFR, so say you've done that EGFR, you've started your PrEP, you don't have to wait for the results, but now the results come back and the EGFR is under 50, all you're going to do is take another GFR, because it might just be an acute kidney injury, but if the GFR is now over 50, then you can continue your PrEP, but if your second GFR is less than 50, you're going to have to stop your PrEP and obviously investigate. In pregnant women, we use that 85 again, so the same rule. You start your woman on PrEP, you take your creatinine, creatinine comes back more than 85, repeat the creatinine again. If it's less than 85, you can continue the PrEP, but if it's again 85 on a second test, PrEP should be discontinued and the patient should be investigated. If you do have renally impaired patients, maybe you've had a patient that was quite sick and had a bit of a creatinine, you can repeat again after 1 to 3 months. And if the kidneys have then recovered, so say the GFR is now over 50 or the creatinine is over 85 in our pregnant woman, then you can use PrEP then at that time. But obviously if the kidneys are not recovering, they're hopefully being investigated to find out why, and you can't use PrEP in those patients. The other scenario, which fortunately also very uncommon, is if you've got a patient on PrEP that tests HIV positive, because remember we're testing them every 3 months. And it's important then to stop taking that PrEP and to initiate them on ART, usually on TLD. And most of the reasons why they actually are having HIV positive on PrEP is usually because they're not taking the PrEP properly. So they're not taking it every day, or they're missing every now and then, or they've actually stopped the PrEP. And it's actually very uncommon to see what we call PrEP failure. So that means somebody who's taking their PrEP consistently and regularly and then gets HIV infected while taking PrEP. And those need to be reported. But we do have other options, not just Truvada. The one exciting option is dapivirine, which is a vaginal ring. So it's a little flexible silicone ring that's got 25 milligrams of dapivirine in it. So that's an NNRTI, like nevirapine. And it's a ring that you put inside the vagina every 28 days, and the woman can do it herself, a bit like putting in a cap, for example. And it was recommended already in 2021. There's been some excellent studies on the ring, and it was approved in South Africa on March of last year for women over the age of 18 years old. So we're looking at how can we get this actually rolled out in South Africa, and apparently USAID is sending 30,000 dapivirine rings in May, with hopefully rollout in June. I think a lot of that will happen through the NGO structure, but they're going to be targeting clinics, pharmacies, community outreach models to make them very easily accessible. And it's already been reviewed by the EML committee that's actually found the costing very competitive also with our other rollout, with our other PrEP options. And then an exciting little development that they're working on at the moment is to have the dapivirine combined with a contraceptive in the ring. So then you can use that for both your contraception and HIV prevention all in one go very nicely. The third option that we will also hopefully have quite soon in South Africa is the cabotegravir, which is the WHO has also now approved. This was in July 2022, and there's amazing studies that has been showing that it's both safe and has had very good reduction as well in HIV acquisition. And why we like this is because it's available as an extendedly release injectable suspension. So instead of having to take a tablet every day, you can have an injection. And it's recommended for adults and adolescents also over 35 kilograms. You would have to check whether people are tolerating it by giving them a monthly dosing of oral tablets just to make sure that they tolerate it nicely. And if they do, then it's an injectable that you start once a month for 2 months, and then after that it's every 2 months. So that's very easy. It's a 3 ml injection, so it's quite a hefty injection, and we'll have to make sure our nurses give it correctly. But also the advantage with the 2 monthly is you could potentially combine it with then Nuristorate and the other bums. So when the patient comes for their contraception injection, they can also have their cabotegravir at the same time. In South Africa, in December, so very recently, we were the second African country to approve the use. I think Zimbabwe was the first, probably with the NGO inputs over there. We don't yet quite know what the costing is going to be, but WITS RHI is going to be piloting this in South Africa later this year, focusing on adolescent girls and young women, and will start giving us an idea of the acceptability and usability in the South African context. So PrEP rollout in South Africa really needs to be fully integrated into our contraceptive and sexual health services. And this is what's supposed to be happening in all our clinics. And I think one of the things we can reflect on is how good are we at making sure that our patients know about this and that it is available for rollout. And whenever you are talking about contraception or STIs or sexual health, whether it's in the sexual health clinic, an OPD, or any setting you're in, we really should be talking about PrEP as well, and all clinicians should be aware of this and be able to offer us. It's a very easy win and easy program. And I was also thinking in terms of our staff health clinics, at our universities, occupational health, PrEP should start becoming part of the conversation. So please go and look at the guidelines, because in it there's some very nice tools. So this is just to show you what's there. It's actually a 2-page tool specifically on a counseling guide. So when you're talking with your patient, how you go through everything they need to know. There's one for adults and there's one for pregnant women as well. And then the guideline also has some lovely posters with the algorithms, which you can put up in your consulting rooms. And it also has paperwork. So it has an actual form that you can use for PrEP initiation, as well as the follow-up for the visits when they come. Also very important is that if you do have somebody that is HIV positive while they were on PrEP, there's actually a reporting form so we can keep track on what the reasons is. And what I think will happen is also we'll follow up how those patients then do on ARVs, and to make sure if this is going to contribute to resistance. Very unlikely, but it would be, we do need to keep an eye on this program. So in summary, PrEP, always voluntary. It's not an enforced system, and it must be very much patient-centered and tailored towards your patient. Key populations, vulnerable groups are global priorities. We really need to start thinking about our sex workers, our MSMs, our transgender people, how we make ourselves open and available for them to have conversations around prevention options. We've got lots of possible options. At the moment, the daily oral pill you will all have access to, but we're hoping very soon there will be a vaginal ring and a possible bi-monthly injection. And remember, PrEP only protects against HIV. We still need to talk about that full package of care around protection against STDs. So thank you very much. We had a lovely discussion in this morning's meeting, which I think focused a little bit about how in the Eastern Cape we can ramp up our training and our mentoring also of our clinicians in facilities to get better uptake of PrEP. PrEP is still very low in Eastern Cape in terms of our targets. And I think it's partly just to awareness. Both clinicians and public are not that aware of PrEP yet. And we need to get to a point where we can actually get our patients to be demanding, coming in and saying, I want PrEP and I want to talk about PrEP. So we will look certainly in this year and focusing more and more about awareness campaigns and workshops for both staff as well as patients. And then just lastly, the references, and most importantly, that 2021 guideline that's available on the DOH Knowledge Hub. Got lots of great tools, lots of great posters. Go and check it out. And I'm hoping that this very week already you can start having a conversation with someone in your clinic or maybe even at home about pre-exposure prophylaxis. Thank you very much.